If you have any reservations, please let me know. With that said, I'm going to hand you over to Nadia Rafif, who's our advocacy and influence lead at ITPC Global. And I didn't introduce myself. My name is Pragashni Murugan. I'm the program officer at ITPC Global, working very closely with Nadia Rafif and the participants on the call today, or the panelists on the call. So without further ado, let me hand over to Nadia.
Thank you, Pragashni. Good afternoon, everyone. Bonjour tout le monde. J'espère que pour les francophones, vous avez trouvé le bouton d'interprétation. And welcome on behalf of ITPC. So this discussion on HIV-TB integration could not come at a more critical time. Across region, we are all witnessing a real crisis. You will be the first, I'm sure, to like you may have been impacted like all of us. Shrinking health budget, disrupted HIV and TB services, growing inequity, and also a dangerous sense of fatigue among global donors. So in this context, integration is often presented as the solution. It's all over those days, a way to make system more efficient and sustainable. But we must ask honestly, is integration truly working for community? And if yes, how it should work? So for many, it has meant more fragmentation and heavier burden on already overstretched health workers. But at ITPC, we believe integration can only work if it starts with people, if communities themselves define what meaningful coordination look like, using their own data, their own intelligence, their own insight and advocacy to ensure no one is left behind. So today, we especially honored to have Blessy Kumar from the Global Coalition of TB Advocates with us today. Blessy is a long-time activist who has been fighting for TB justice for decades and who know well what HIV and TB integration mean and how it should like. And she's joined by a very other inspiring community leader from India, Kenya, Malawi, and Zimbabwe. But I will let Pragashni introduce everyone later. So as we listen today, let's not only ask how to integrate, but why and for whom, because integration that doesn't strengthen rights, equity, and accountability is not progress. So very excited to hear about different experience, and I hope you will have also the opportunity to participate to the discussion. Thank you, everyone, and back to you, Pragashni. Thank you.
Thank you, Nadia, and it gives me pleasure to introduce to you our powerhouse of panelists, joined by a lot of key individuals that have been involved in HIV and TB for many, many years. Firstly, and as introduced by Nadia Rafif, we have Blessy Kumar, who's a health advocate with special expertise on TB, focusing on community engagement. She has worked with varied communities across India as well as Sudan. She has endeavored to bridge patient-practitioner divide through patient literacy at the community level and advocacy at a macro level. For the last 18 years, Blessy has focused on TB. She has built capacity of affected community members and advocated for their inclusion in TB policy and implementation bodies globally. Then we are joined also by 3 or 4 community advocacy network members who are firstly Nelson Otoma from Kenya, who's the director of NEFAC, that's National Empowerment Network of People Living with HIV in Kenya. Nelson is a committed public health advocate and director for NEFAC. In his role, he provides strategic and accountable leadership to amplify the voice and visibility of people living with, at risk of, and affected by HIV. We also are joined by Lawrence Konyongwa from Malawi. Lawrence is the Executive Director of Malawi Network of People Living with HIV, Manet Plus. He has worked to improve the lives of people living with HIV for over 20 years by promoting appropriate and sustainable community responses. From our Community Advocacy Network Advisory Group, we are joined by Grace Narayat from Kenya, who's a program officer at the African Sex Workers Alliance in Kenya. Grace is a feminist sex worker advocate with a background in monitoring and evaluation, working for the African Sex Workers Alliance as a program officer, where she coordinates the Sex Worker Academy across Africa and has worked for HIV programming and populations at higher risk for acquiring HIV since 2015. We are also joined by Cloretta Gwanzura, who's the medical officer at the Ministry of Health Zimbabwe, working in differentiated service delivery, HIV TB integration, as well as community engagement. We are also joined by Rudo Kuenga, who's the regional clinical advisor at ICAP Columbia University's Sequin Network, as well as Dr. Dio Ndubuka from Rwanda Network for People Living with HIV, who will be supporting the closing the session on the reflections. With that, I would like to present to you the agenda for today. Framing remarks on HIV-TB integration will be conducted by Blessy Kumar from the Global Coalition of TB Advocates. She will focus on letting us or informing us on how integration tackles funding gaps, what are the definitions of life-saving integration, as well as zooming in or narrowing down on community engagement for integration and sustainable impact. We are also joined by Bactrin Kilongo, who will be moderating this session. He's the technical advisor at ITBC, and he will moderate the session with the Community Advocacy Network, as well as the panelists from the Zimbabwean Ministry of Health, and he will moderate the session on examples of community engagement work in HIV-TB integration, focusing mainly on the community response to integration and insights for sustainable integration. We will also have a 10-minute discussion or Q&A session, so please feel free to add your questions under the Q&A box, and we will ensure that we answer your questions appropriately and adequately. We are then followed by a reflection section by Rudo as well as Dio, and thereafter we will close the session with a few closing remarks. With that, I would like to introduce to you our Community Advocacy Network, which is a collection of representatives from people living with HIV, or networks that amplifies community voices across key learning networks and communities of practice in the HIV coverage, quality, and impact network, which is Sequin, and the laboratory system strengthening community of practice, also known as LabCorp. We have been engaging with the Community Advocacy Network for the past, I would say, 3 or 4 years. With that, we have developed insightful and valuable resources based on the powerful data that the communities have been being collected over these years. And we have managed to track not only how they monitor HIV differentiated service delivery, but also how communities have been extensively involved in using this data to drive advocacy as well as sustain community. So if you need any more information on this, please feel free to log in onto this using this URL on our ITPC website. With that, I would like to thank you, and I will hand over to Bactrin. And please ensure that you introduce yourselves within the chat box. We would love to see where you are from. Thank you. Over to you, Bactrin.
Great. Thank you very much, Pragashne. Good morning, good afternoon, good evening, good people. Thank you for joining this webinar. I think we'll just go straight into it and ask Blessy, my sister Blessy, who we've done quite a bit of global work on TB together, to set the scene for us, essentially looking at how things have been over the last 2-3 decades in the world of TB, the efforts of integrating TB and HIV, and some of the things that need to be done. So over to you, my comrade and sister Blessy.
Thank you very much, Bactrin. I don't know why you can't see me. My video is on, but maybe it will come on. But good evening, everyone. Challenges of living in the global south, I guess. But I'm absolutely delighted to be here with all of you. One thing great about my colleagues and comrades from Africa is that we refer to each other as brothers and sisters. And that for me lays the foundation of everything. If we are together, if we feel we are a part of family, then we can achieve great things. So big thanks to ITPC and my brother Bactrin for inviting me to be part of this. And I try to bring from my experience, from our experience, what I think should be done, what are we doing wrong, what can we do right to ensure that this collaboration continues or is made stronger. I've already been introduced, so we'll just go to the next slide. And I'd like to introduce the Global Coalition of TB Advocates, which is GCTA. I think many people here are part of GCTA as well. So basically, it's a coalition of TB affected individuals, bringing the lived experience of TB to the global platform. And any global policy that is not based on ground realities will not be something that is useful for us that work at the ground level. So this is the main focus of GCTA. And we also endeavor to bridge that gap between civil society organizations and other stakeholders, while ensuring that community is involved in all TB processes. And this is through issue-based advocacy, coalition building and strategic communications, improving governance, accountability, and representation. And of course, building the capacity of communities across. Next slide, please. So GCTA today has about 560 plus members across 72 countries. And we hope to grow that a little bit more. But in this time of crisis, it is a challenge. And, we just need to keep holding on to hope and move on. Next one, please. So what is it that we are afraid of when we talk about collaboration or integration? What are some of the barriers that are inhibiting us from moving towards this collaboration? HIV and TB specifically, why are we not working together? So I've put them into 3 different groups. One is the funding silos. And here it goes both ways. The funding that comes in and the funding that we receive. There are separate budgets for it. There is also competition for grants. And there's also the resources that are less shared. So that is one big fear that we have. The second one is that we will lose that spotlight or recognition. We all desire credit. We want to be known. We want our organization to be known. We want the brand to be identified and protected. And because of this, we duplicate our efforts. And this is another big area that is a barrier. The third one is the operational silos. Because we lack integrated planning, we are working very much separately. We have separate staff, separate training, and fragmented care for communities that are affected. And all these actually result in that missed opportunity and worst people outcomes. If we just stop and think and try and overcome these barriers, the opportunities will be great, and the people at the ground for whom we all work will have much better outcomes. So according to me, it's not a question of choice of whether we want to work together or not. It is just that we have to. Just to give some examples, if we look at the proposals, many proposals, I just want to give one example of the Global Fund proposals, because Global Fund was very particular a few years ago that no HIV proposal will be accepted without a TB component and vice versa. No TB proposal will be accepted without a HIV component. Fantastic. But what happened at the ground level? Many of you will probably be able to identify with this. In my country, the HIV group sat in one room, the TB group sat in one room. We wrote separate proposals and then copy-pasted it together. Now, for me, that is not real collaboration. We weren't talking to each other, we weren't working together, we weren't looking at solutions together. So it was a bit of a disaster at the community level. And at the ministries as well. You know, ministries become like little kingdoms. Nobody wants to share that with each other. The funding, the fame, the spotlight, the recognition. And I think if we want real answers, real change at the ground level, we need to move away from that. And who can hold ministries and governments accountable? It is the communities. It is you and I who have our hands on the ground, who can actually challenge the status quo that exists. And sadly, this is also translating into the NGO sphere. The programs that we manage also tend to act in the same way. And I think it's time for us to actually put our foot down and say enough is enough. And we are not going to, accept this anymore. Next slide, please. So how do we do this? I want to share a very small example. Again, it's collaboration is not rocket science. It is something very simple. Our communities have been used to it, especially in Asia and in Africa. We are very community-oriented people historically. We know the value of working together. So just to share with you, we had a small project, and I want to share this whole thing about cross-disease network, shattering silos. So our objective was to advocate for accelerated rollout of TB preventive treatment. And we started this work towards the end of 2022. And the situation when we started in early 2023, when we did a community-led monitoring, we found that there was suboptimal engagement with the community in a meaningful manner. Only 6% of eligible household contacts had received TB preventive treatment in 2022. The short-term regimen wasn't even thought about. People were still getting only 6 months of INH, which was ruled out according to the WHO guidelines. But they were being provided this with no pyridoxine, even though the guidelines very specifically mentioned when you give INH, you need to give pyridoxine. We saw and found that that wasn't the case. There was issues of short supply. There was limited knowledge and awareness about what is this TPT, which meant that there was no demand from the community. And because of lack of knowledge, the uptake was also very limited. And 3 months of rifapentin and INH was not part of the country plan in India. So this was the situation. So what did we do? Next slide. So we did several things. We brainstormed and we said, the HIV group crying, TB group shouting, other groups shouting, it doesn't work. We need to come together and make our voice one and loud and clear, which is what we did in 2023. We formed the Cross Disease Network. We had people living with HIV, the HIV network leaders, the people who use drugs, LGBTQI+, sex worker network, TB survivors, all came together and we started advocating. We wrote letters to the Prime Minister to roll out 3HP and 1HP. We had meetings with NTEP. TB advocates are very nice people. We are very soft. We are so gentle. We don't challenge. But we had our HIV activist brothers and sisters who had been used to shouting. So when we went together, people actually got a little nervous. They said, where have these people come from? So we had several meetings with NTEP. We had community meetings. We developed a community brochure on what is TPT. WHO guidelines are okay, but communities can't relate to that. So we made something that would be acceptable and understandable by the community. And this TPT brochure gained so much of interest that it is now translated into 11 different global languages. So something very small, answering questions that communities have is what is really valuable. We also started updating TPT guidelines. We conducted CLMs. We continued our advocacy with local leaders, elected representatives, and different people did it in different areas. And then we had several in-person meetings to evaluate where are we, what needs to be done. And these were all very small initiatives with very, very small budget. What happened in 2024 April? There was success. The TB preventive treatment was rolled out in the highest burden TB country in the world, in India. And this was because we worked together. So my friends, brothers, sisters, collaboration, integration works. Our voices get stronger and heard when we work together. Next slide, please. So what does real integration look like? Taking on from what I shared from GCTA experience. There's enhanced outcomes for communities. There's improved diagnosis and treatment. There's reduced morbidity and mortality. I mean, one of my biggest dreams is to see that death figures come down in TB because TB is treatable, is preventable. And of course, there's better treatment adherence. And who knows this better than HIV networks? The importance of taking medicines regularly. So there's a lot to learn. Cross-learning, knowledge sharing is so important. Then real integration also means optimized resource utilization. Rather than doing little bits in silos, if we come together, it's cost effective. Combined trainings. I've just come back from a training in Mumbai where we had the HIV network leaders and TB network leaders coming together. And it was a great a time of learning and sharing together. We have efficient service delivery. The impact is maximized. Little bit of impact that each of us think about, put together becomes a huge impact, and people will sit up and take notice of us if we come together. And of course, there are the public health benefits. The transmission in the community of diseases comes down, and there's also we can achieve global targets much better. So this is real integration. Next slide, please. So real integration and collaboration, like I mentioned earlier, it's not a choice anymore, especially in these crisis times, unprecedented times. We've never seen like this. We need to come together. We need to maximize impact. We need to be cost effective. So it's not an academic exercise that we can write about, but these are actually actions that lead to lives being saved. And real integration requires deliberate and intentional efforts. It's not going to magically happen just because somebody thought about it. It needs those of us to put our hands down to the ground and do something about it. And also, people talk about person-centered care, but I don't see it realizing or translating. But if we have real integration, this puts the person-centered care as top priority. And also it's a win-win for all. And here I want to really quote Nelson Mandela, who said in 2004, the world has made defeating AIDS a top priority. This is a blessing, but TB remains ignored. Today, we are calling on the world to recognize that we can't fight AIDS unless we do much more to fight TB as well. I mean, what a fantastic, wise words way back in 2004. And 20 years later, how much of a reality is that? One of my colleagues, PLHIV, told me, I've learned to live with HIV, but I think I'm dying to TB. I mean, what, that laid so heavily on my heart. And he did pass away from TB. So there's no point in working for HIV, AIDS, and people, learning to live with it if we are only going to let the same people die of TB. So integration is so core. It's so much the heart of keeping our colleagues, ourselves, our communities alive and functioning and kicking. Next slide, please. So way forward, very, very quickly, we all have a role to play. It isn't something that only communities should do. It isn't something that policymakers do. We all have an equal and important role to play in this. The communities know the pulse at the ground level. We need to be willing to inform. We need to show that we will work together at the ground level. Implementers, the larger civil society organizations, need to lead by example, because you have the ability, you have the capacity. Show the world that this is something that is possible. Very important for donors to understand this, because they say donors have their finger on the needle. Donors push it to the left, everybody goes to the left. They push it to the right, everybody goes to the right. Whether it is good or not, that is the reality. So challenge our donors. Our communities speak on behalf of donors. Challenge them to ensure that real integration is something that is looked at seriously, something that is costed, something that is funded, something that is recognized as something that is needed, really, really of great need in our disease responses. Policymakers, people who sit wherever, WHO, other technical partners, they need to also understand that you can't work in silos anymore. WHO has brought together HIV, TB, STI, Hep C, all together under one department. And I think I was one of the very few who was happy about it. Many people said, oh no, but we'll lose funding for TB. But I think that's a good thing. And then, of course, technical partners who are building the capacity globally. They also need to understand what's the point of everybody else doing that. And then some technical partner or some consultant zooms into the community, to the organization, and then suggest working in silos that will destabilize everything. So everybody needs to understand this. And if we want to push for collaboration, we need to speak the same language. All of us need to be talking about it so that the message is very clear. It doesn't confuse people. Be very clear of what is it that we want, why we are saying this works, and why we want investment or funding or whatever into it, resources put into it, because that's the only way we can go. Next slide, please. I think that was my last slide. So thank you very much for inviting me, and I hope we have a great rest of the session. Thank you.
Namaste, Blessy. That is one loud voice, and your message essentially is to have one single collaborate, many people coming into this one loud voice together. I think that sets the stage for the next session, where we will hear actual work going on the ground that is community-led. Because as you said, Blessy, real integration is community-led. Anything short of that is fake. And so we have folks, my comrades here, who will try and share with us how they've responded to this call for integration, how they've done, how they've been involved in integration, and then give us some insights on how this can continue and actually scale up. So first off is my comrade from my mother country, Nelson Otuoma, from NEFAC. Nelson, over to you. The next less than 10 minutes. Thank you.
Thank you, Baktrin, and thank you to the ITPC team for giving me an opportunity to also share from the Kenyan perspective what we have been doing in this area, this crucial area of TB, HIV integration. And thank you to Blessy for giving the background why this is important, and I agree with you that TB remains the leading cause of sickness and death among people who have HIV, and we need to take it seriously. So I'll do away with my photo to have a clear voice, and in the next few minutes I'll be taking you through what I've put here as an outline, but basically what has been happening in Kenya and giving some recommendations. Next slide. Yeah, so basically I already got introduced by Craig from ITPC, but I want to say that I work at NEFAC, and NEFAC is a national network that brings together people living with HIV in their diversity, including KPs living with HIV and also including those who are affected. Some of them also have TB. And this is a network that aspires for a nation where recipients of care, in this case, people living with HIV mainly, are in the forefront and meaningfully involved with the interventions geared towards improving health and well-being. And what we do basically is that we leverage on the lived experience and channel this, what we get in lived experience, to policy, programming, and service delivery. Next. Yeah, so I concur with what Blessy was saying, but basically we are talking about two colliding epidemics that probably may even be one, and this remain a public health challenge in Kenya. And also we know that Kenya has made commendable progress in this area, but challenges remain. So in terms of co-infections, the latest data show us that there's a HIV-TB co-infection around 25-26%. And what this means is that among those who have TB, 25% of them also have HIV. So it's a shared epidemic, and also HIV is fueling the Kenyan TB. And as I've said in the beginning, TB remains the leading cause of sickness and death among PLHIV. So in the NEFAC membership, as we monitor deaths, particularly from adolescents and young people who should not be dying now, we realize that after they died, we always realize that chances are this was TB that missed. And of course, we talk about AIDS-related deaths, but these are TB that is killing people in the HIV. And we also know that TB is a leading manifestation among those who present with advanced HIV disease. And of course, this is not a recent thing. From the outset, the Ministry of Health in Kenya recognize the dangerous relationship between TB and HIV and put in place mechanisms to reduce the burden of TB among people living with HIV. So Kenya has been having a long history and successes and also challenges in terms of TB HIV integration, but also I think this is a country that can offer some lessons when it comes to how do we integrate. And right now we are integrating beyond TB and HIV. Next slide. Yeah, so when we talk about this term, we talk about integrated people-centered health services, including what we talk about here today as TB HIV. And Kenya, like most of sub-Saharan African countries, the success and the commendable progress we have been talking about in the field of HIV and TB has been in our reliance on external financing. And of course, this year around February, there was a jolt with the funding pause. Although the limited waiver came in, the injury already was caused. And the Kenyan Ministry of Health realized that there was a gap left when this donor funding went. And of course, we are not just talking about the US government funding pause. Subsequently, the Global Fund also came in and they're using a language we call reprioritizing. But basically, what they're doing is the same as what the US government did, only that they are not doing it dramatically and noisily as it happened from the US. They are doing it systematically and silently, but the effect is the same. It's a budget cut. So what happens is that even as we move forward, community engagement is recognized as a key pillar in both TB and HIV response. And communities, in this case, in Kenyan case, NEFAC has been engaging policy programming and service delivery. And the Ministry of Health has prioritized this and put up structures and platforms for engagement of recipients of care, TB, HIV integration agenda. Next. So for us to make sure that we represent the voices and visibility of communities, in this case, recipients of care from both HIV and TB, we are strategically and visibly present in mechanisms, platforms, and structures. And that includes committee of experts, like working groups. These are set up by the Ministry of Health. This is where the work is done. But outside that, we also implement with the support of Global Fund. So we are engaged in service delivery for both TB and HIV, and also where they interact, like the true integration. So we also undertake community-led monitoring, and we have benefited from ITPC and partners in this area. And one of the things we did with the support of ITPC was to make sure that we included indicators of TB HIV integration in our CLM framework. And as a network, we also provide a platform through which targeted advocacy and communication is mounted for sustainable TB HIV integration. So our advocacy work also makes sure that we push the integration to work. Next slide. So basically, this table and a crowded slide is just to summarize what we do in the space of TB HIV integration, and specifically in 4 areas. We work to train TB HIV champions so that they understand both the sciences and how to engage the science of TB, the science of HIV, and how to make sure that service delivery is done at the same level and policy is also merged. We also undertake partnership, and one of the partners I wanted to appreciate is the network of TB champions. I'll be acknowledging that has come up to do a lot of advocacy at the community level, but we also partnership with the Ministry of Health, and we engage in the Ministry of Health platforms, like I've talked about, health sector working groups, and then we also undertake service delivery. And we have been part of this team, the community network, the CAN, that now today is hosting this with the ITPC. And we have used the framework, developed a framework for community engagement. And we have been engaging at policy, programming, our guidelines, and facility or community level. So I've just given examples here of our engagement with the health sector working group, and making sure that we attend acceleration meetings that were supported 2 meetings by the World Health Organization when they realized that there is a lag behind. We also went for the HIV Service Delivery Integration Summit. That's a high-level policy, and then for us, there we had to make sure that don't just talk about integration of HIV into healthcare, talk about TB HIV integration. And of course, we have engaged in the Global Fund prioritizing, but just to make sure that we safeguard the community engagement and also issues of TB HIV integration, including advanced HIV disease. And we continue to engage in MOH and partners, including forums like the CCM to the Global Fund, to make sure that we give feedback whether this integration is working or not working. And the challenges, like Blaise was talking about, the issue of docket that I'll talk about when we reach part of the challenges. At programming level, Kenya is almost launching its integrated guidelines. This is for HIV, but our role as communities was to make sure that TB is not left behind. Kenya released HD implementation guidelines, which we participated in, and we made sure that apart from saying TB is an opportunistic infection, is also a condition that need the attention of HIV programmers. And of course, we are part of DSD committees and laboratory assessments that we always work on to share with the Sequin network and other partners on how best to improve. But our role really is, because this is a Ministry of Health-led initiative, our role really is to make sure that the input from communities is taken care of. And of course, I've talked about ensuring that we have indicators for TB HIV integration in the community-led monitoring, so that we do data collection, analysis, feedback, and then based on that, we do advocacy. At a community level, we make sure that we sensitize the recipients of care on TB HIV interactions and make sure that they are creating demand for services for screening and also for diagnosis. And if one has active TB disease, then they can demand care. And then we mobilize them to make sure that they advocate for laboratories and diagnostics. This is the challenge. Like you realize that traditionally we were depending on microscopy, then we moved to X-ray, then we had to demand for molecular technology, gene expert, but challenges still persist. And I've talked about service delivery with the support of Global Fund. Next. So we have experienced a few challenges. There is the traditional challenge of coordination, structured, meaningful community engagement. And basically with the funding disruptions, we are talking about human resources. And of course, staff layouts of both TB and HIV in the frontline clinics is a great challenge. The specialized care probably is out of place, and therefore the Ministry of Health is also working very hard and struggling to make sure that they bring and train in new people to understand. And it takes time to understand the space of integration. Of course, there is the issue of donor restrictions affecting both community engagement and also the integration. And you will agree with me that if you look at both PEFA or US government funding pools and Global Fund reprioritizing, what was sacrificed was the part of community engagement. I think they are going to be commodity heavy and government to government. And that then compromises the issue of community engagement and also the issue of TB HIV, particularly the prevention of HIV has suffered. There's the traditional issue of this is my docket. Of course, this is a Ministry of Health thing. TB department sometimes think the HIV program is overbearing, but I think also at community level, there are communities that think that the PLHIV are taking too much. Of course, you realize the campaigns of somebody saying even Global Fund need to reduce the HIV funding so that they fund TB. But this is simply because they don't understand that these are two colliding epidemics in one individual, and therefore either money is useful regardless of where it sits. What we need to intensify is integration, because even from the HIV point, we know that for those who adhere on ART in time, that wards off the cases of TB. But this has affected us because sometimes you come to countries like Kenya, gene expert, which actually can even lend support to viral load. Sometimes the docket issue, the TB program may not be happy to release it to support an HIV initiative, but this is part of the dialogue, and this is why we need community voices to say that technology should be working across any disease where they can be useful. And of course, we always ask where is the money? Right now, we are moving into country ownership and government-to-government approach, and they are likely to prioritize biomedical interventions. They will buy ARVs, TB medicines, but community engagement and demand creation and issues that will help us advocate for integration are being compromised. Of course, we know that these are two conditions that are still highly stigmatized and to some cases criminalized, and therefore this hinders optimal integration and community engagement. Next. Yeah, so this is just to remind us that when we did a PLHIV Stigma Index 2024, we realized that both TB and HIV are stigmatized, but people who present with both conditions are more stigmatized. Of course, we can get into details, but we don't have the time for that today. Next. So we think that moving forward, meaningful engagement of recipients of care in this integration agenda require that these recipients of care, whether TB or HIV, are empowered, are resourced, and are capacitated, so that we are also not fighting in the room for the same thing, but we also understand the science of both diseases. So that is why my number one recommendation. The second one is that Ministry of Health need to embrace community-led monitoring as a mechanism for providing feedback on quality and how improve integrated TB HIV services. We realized during the funding post that some Ministry of Health were really slightly excited that right now they don't have donors who will be calling upon them to support community-led monitoring. And I think that is a misgiving that we probably don't need to have going forward. We also recommend that government and partners should not be sacrificing community engagement in the face of declining donor support. But those who have been tracking both PEF and Global Fund, what has been deprioritized has been community engagement. But now we recommend that strategies like social contracting framework should be put in place to make sure that recipients of care also have resources to continue to engage. Lastly, and more importantly, TB and HIV treatment education and also on self-care to enable recipients of care to take charge of their responsibility, and also to make sure that they create demand for TB, HIV services and information. I think I'm moving to the last slide. Thank you. To just say thank you, and I wanted to thank the Ministry of Health Kenya for providing us with the space, and also the network of TB champions for doing the advocacy at the groundwork. Thank you very much to the team. Back to you.
Thank you very much, Nelson. That was insightful. I will now switch countries and go all the way to Malawi and get to hear what Manet has to share through Lawrence. So, Lawrence, over to you, my brother.
Thank you very much, Bactrin. I will make a presentation on Malawi. So this presentation is for the whole country. It's not just for Manet Plus. Next slide. As has been explained by Nelson, we have also been implementing a joint HIV and TB program. Our Global Fund program, we submitted joint TB and HIV application. But just to echo what Blaise said, that is in the concept note when we submit, but during implementation, we have separate subrecipients for HIV and we have separate subrecipients for TB. So that's where sometimes the disintegration starts. However, when we go into the actual implementation, we see that at community level, there is integration of activities. So the program that we have in Malawi, the major target are men, women, people living with HIV, people from mining communities, and others. The main aim of the program is to reduce the number of new infections towards the elimination of HIV transmission by 2030, reduce HIV-related morbidity and mortality, and reduce morbidity and mortality from tuberculosis. So that is the main objectives and goals of the joint HIV and TB program. Next. The major strategies, you will see at the strategies that they also look at integration. The major indicator for the project, especially on TB, is the number of notified TB cases or forms contributed by non-TB program providers, community referrals, and you should underline non-TB providers, meaning that there are other providers that are specific to TB. So that's where the integration starts. In order to achieve this, the project has used the following strategies: developing the capacity of existing community sputum collection volunteers through mentorship and supervision, in addition to provision of enablers and the use of modern technology for data collection, peer groups and expert clients engagements to strengthen and engage peer groups and expert clients to effectively promote health equity and reduce stigma and discrimination. Take note that most of these expert clients are either living with HIV or TB survivors. The third one is TB awareness and health promotion to strengthen community health education and promotion to enable people to make informed decisions, reduce stigma, improve health-seeking behavior, and adopt effective TB and HIV preventive measures. So this health education is provided by volunteers at health facilities as well as in the community. The fourth strategy is combined paper-based and electronic data collection methods, which ensure data flow and reporting. Community sputum collection points use paper-based method, which is given to lead volunteers for purposes of entering into electronic database. So as a country, we are moving into the digital age. The collection of data can be done by using paper and pencil, but we put that in electronic devices in order to ensure that the data flow is very accurate and can easily be put into dashboards. Next. The key activities for the program include conducting TB screening, that is case finding, including house-to-house mass screening campaigns. As you know, finding a TB case is like looking for a needle in a haystack. So the population is large, and you really have to find a positive case. So the ministry has two parts: the OPD, which means a patient has to go to the hospital to present with a program. But if the person does not go to the hospital, then the community has to identify that person, take sputum, and then put it to the laboratory for testing. So the second activity is collection of sputum samples, initiation of referrals for testing and treatment, deliver the results to individual recipients of care. So once the laboratory has done the test, The result, whether positive or negative, is supposed to go back to the specific recipient of care that provided the sample. And it's not very easy to do that. The other activity is providing treatment adherence support to both TB patients and people living with HIV. Usually we talk about adherence mainly for people living with HIV, but at community level, adherence is both for TB, HIV, for NCDs, for anything, any care that is there. Issues of adherence are very important, and the community are very good at that. They don't distinguish which condition. The project also provided health education at health centers and in the community, as I already said, and ongoing documentation of data, compiling and submission of monthly reports. So the picture that you see there is one of the sputum collection points in a place called Palula in Malawi. So those are some of the forms that they use to enter data, do the analysis at community level before submitting to the health facility. Next. So these are some of the outcomes, but for most of the outcomes that Malawi has, you can just copy and paste from Nelson, Dale, Grace, and Blessy presentations. But in addition to those outcomes, the Ministry of Health Integrated Community Volunteers Training Manual that we have as a country has HIV, TB, and malaria components in one document. So already, the community manual is combined. Everything is there. You don't need to have to look at HIV manual, TB manual, malaria manual. It's in one document, which shows integration already promoted by the ministry. One of the outcomes is that just the second quarter of 2025, 21% increase in TB case notification was attributed to the increased case finding effort at community level, which was 12%. This means that all the cases that were identified, 12% were identified by community volunteers through community sputum collection points and house-to-house TB screening interventions. What it means here is that if the community did not do their work, 12% of the TB cases would still have been there in the community without being diagnosed and without the people being linked to treatment. So it means TB would be spreading without control. 10% contribution was from mobile diagnostic units. Our ministry procured mobile diagnostic units, and the campaigns that are done at community level are also enhanced through the community volunteers who mobilize people to attend the campaigns. Next.
You may need to wind up, Lawrence.
Yes. So in winding up, I'll just say that we have also seen a lot from CLM data. We have additional sputum collection points, increase in the number of sputum collection volunteers. The problem of missing samples has been eliminated in many places. This is just one example. We also have increase in ART service days, reduction in default for both ART and TB medication, increase in number of men attending antenatal clinics for HIV. There were also no ART service providers in one place, but now we have more HIV service providers. Next. Yes, thank you very much. That's my presentation. Over to you, Bactrin.
Great. The mute thing is refusing to come on. Thank you very much, Lawrence. Again, great insights. In the interest of time, I will want to introduce the next two great sisters that I know, and at the risk of being gender insensitive, we have 10 minutes for each of you, so please keep to the clock. Grace, share with us the aspects around the KPs and particularly the sex workers that you have worked with over the last years with regard to integration. Over to you.
Thank you, Bactrin. I hope you can all hear me well. And thank you to the previous speakers. You know, sometimes it's hard talking when your leads have talked. And thank you, Nelson, for bringing up the context of Kenya. As I am here under sex workers, but I'm going to talk about key population joined. So this presentation that I'm going to do highlights community-led actions, gaps in the current approach, and also urgent actions that are required to protect and sustain the gains that we have made in the KP programming. So on the community-led actions and contributions, we've held 4 consultations, so 2 virtual meetings and 2 in person with the Ministry of Health, that is the CASCOs and the all key population typologies. These meetings aimed to ensure a participatory transition, but did not yield the expected outcome. So with key populations consistently raising concerns about lack of clarity, dignity, and also meaningful participation. So we've realized that when meetings are called, sometimes you get the invite few hours to the meeting. And also with the lack of resources, you might not be able to attend the meeting. So KPs also are not in agreement with the forced integration and with the view with the current process as undermining human rights and years of progress in community-led HIV programs. So in that response, the key population community developed and submitted the key population implementation plan towards sustainability. It was a community-led alternative to the top-down integration plan. So this plan deliberately excludes any language on integration, on transition, and emphasizes on autonomy, respect, and sustainability. But we've had some backlash on acceptance of this sustainability plan. So, and we've also advocated for typology-specific approaches rather than lumping all key population under a term of key vulnerable population, because we understand that key population have their different needs. People who inject drugs, some of them are on methadone. A number of sex workers, some of them are not on methadone. So lumping all key population under general term and coming up with a plan for all of them might not lead well. So with this, I'm going to give 3 case scenarios, that is Busia, Kisumu, and Nairobi. So we have a team working in Nairobi, and this is to let you know that Nairobi and Busia were 100% USAID funded projects, and Kisumu was CDC PEPFAR. So in both Busia and Kisumu, we've seen some of the achievement. So the Kisumu and Busia team have secured office space within the government facilities, which were really is a good thing. And also in Kisumu, the county government involved the key population in commodity distribution. So that one was given to them. And currently they are working on MOU on how the key population community can manage the commodity distribution. So there's also an MOU and a negotiation with the Busia team so that they can be able to carry out the services at the MOU facilities. In Busia also there's community data reporting tools in the 16 Busia facilities. So they were given the facilities were distributed with community data reporting tools. So when community goes to those centers for services, the tools are there to collect the data. So it has been good in Kisumu and Busia that KP leaders were involved in facility selection and planning. So the leaders were called, they were given list of facilities where key population, mostly the sex workers, were choosing the facilities that were nearer to them, that they would access services and they would feel comfortable, and all the charges that they were in. So it is something that someone chooses with all the information that's been given. So in some areas, there have been supportive healthcare workers. And in Busia and Kisumu, they have been assigned a government liaison officer who had facilitated this smoother engagement and currently is ongoing. Next slide, Bakri. We've had some promises in the practice of integration. So the key population community engagement in planning in Kisumu, Busia, that one I've talked about. Next slide, Bakri. I think I've summarized all this. So we've had some challenges as we were speaking, and these challenges mostly comes from Nairobi and Busia. These are facilities that were 100% funded by USAID, and they are 100% community-led. Kisumu was an implementing partner with an MOU with community-led organizations. They were working together. But in Nairobi and Busia, these are 100% community-led organizations, and they were 100% USAID funding. So there is a high level of stigma and hostility because you understand this is a community that is criminalized also and stigmatized. There's also no clear SOPs of transitional guidelines from the Ministry of Health. This has led to the key lead taking community to access services, but the facilities they go to tell them that they don't have that communication. So it has been hopping from facility to facility, and the facilities lead saying that they don't have that communication of having key population accessing services into their facilities. So also forced transition seen as a rights violation, risking reversal of KP-led gains. We've had a lot of gains, and this forceful transition will lead to the gains not being seen well. So stigma and discrimination from healthcare providers is still there. And it's really making also the community not being able to access services, and some of them have gone to defaults. So not accessing both prevention services and care and treatment. So lack of clarity on CSO's role post-transition. So we'd also want to have clarity on what will be the role of CSOs post the transitioning of the integration of health services, so that they can be able to see what they can do and what's next for them. So poor communication between government and community has led to, mostly in Nairobi, has led to integration to the facilities that were closed not being able to operate well. So it is something that the team leads, the key population leads in Kenya are looking at how this can be worked on, and facilities having MOUs with organizations so that they can have a smooth transitioning. So as I said, in Nairobi and Busia, there's coercion and threats from CASCOs. This has been reported case studies and documented. So also facilities are unprepared to receive key population. I think the stigma and discrimination that goes, and criminalization that goes with key population, most of facilities fear, and also the facilities not being able to understand what is the minimum package for a key population client when they come to seek services. There's also fear the community systems are going to be are now going to not to be there because the community system has really helped us in linking the community to the facilities. So no stipends for key peer educators, we think by next month, because it ended this month. No, it ended in September. So this month, we don't know how we are going to sustain the key population, the key peer educators who have been carrying out the community systems and making sure that their fellow peers access services. So there's also fear of uncertainty over future support and access. This has been a fear to all the leads. Next slide, Bertrand.
Yeah, as you wind up.
Yes. So what we have as a solution for sustainable integration here, we are ensuring that funding for peer educators is sustained. The Kenyan, we have system of CHVs, so the key population teams are in talk with the government. If the CHVs, some key populations can be picked as CHVs to make sure that the outreach system is sustained. So leverage the key population implementation plan towards sustainability as a guiding framework, and also protect drop-in centers and prevent their abrupt handovers, or have a clear guide on how this transitioning will be smooth, and also develop and enforce clear transitions SOPs in consultation with key population, not just coming up with SOPs without involving the key population. And lastly, now train healthcare providers on stigma reduction and letting them understand what key population service package is. I think with that, I'm done, Bertrand, and thank you.
Thank you very, very much, my sister. That was awesome. And I think that paves way for our other sister to, in a very short time, my colleague, Clorata, please give us Ministry of Health insights on what integration work has happened in Zimbabwe in 5 minutes, if you can. Thank you. Over.
Thank you very much, Bertrand. Unfortunately, being the last person, I'm going to have to fly past. We can go to the next slide. So this is the outline of my presentation: country context, implementation, and also community engagement. Next. So this is just summarizing where we are at as a country: 1.3 million people living with HIV and HIV prevalence of 10.5. And just zoning in on TB, our estimated TB incidence was 204 per 100,000 population. And our treatment coverage has been increasing, which is something that we are celebrating as a country, though we still have a significant number of people that we are missing each year. Next. So the next slide is also continuing with country context. We do have a double burden of TB, HIV, and MDR, but we are also celebrating just Zimbabwe recently was removed from the top 30 countries that are heavily burdened with TB. We still have high incidence of TB, HIV, but this has also been coming down. So we are happy that our efforts, they are bringing us the results that we expect. Next slide. And this slide just tried to condense how we've been doing, especially with TB preventive therapy from the time that we started. So far, we have managed to reach a significant population of people living with HIV with TB preventive therapy. Between 2022 and 2023, we actually had an accelerated phase where we wanted to reach every person living with HIV with at least a course of TPT, and we managed to reach 81.6% of our target, and that really was a game changer for us. Next slide. So what have we done with community engagement? I think a lot of things that were presented by Lawrence and some of our Kenya colleagues are also things that we have done ourselves. We have a TB HIV technical working group. PLHIV are represented as a member of that technical working group, not just as people who are part of that, not just a chair, but they have a voice. And when we have activities that require community, the way they are the ones who take the lead. We have done, we have co-created integrated guidance on community capacity, a number of tools. We're part of that. So we have a job aid. We have TB in the HIV treatment literacy manual for people living with HIV, and also have an expert training manual that trains recipients of care, peer and expert patients on TB and also TB HIV integration. We do have IEC materials, and on some of the pamphlets, especially those speaking to people living with HIV, recipients of care led on those ones. We also had videos and skits, and they also led on that. We were just providing technical information, making sure that the information is correct. But that is how we've been doing that. And we also have TB data points included in community-led monitoring. So we are receiving positive feedback from the recipients of care and people who are receiving our services. And we have seen that this has really strengthened our programs, because we're not just monitoring from our end, but we're also receiving feedback that further allows us to provide quality services in integration. Next slide. And these are examples of some of the tools that I mentioned in the previous slide that we developed together with recipients of care. And these recipients of care are not just the group for people living with HIV, but we also have civil society organizations that are representing TB survivors, and they are part of this work that we've been doing so far. Next slide. So what are some of the lessons that we have learned? So I know this is a highly summarized presentation, but I just zoned in on community integration, though there is a lot that has been happening in terms of integration within the health system. So integrating TB, HIV, and NCDs, this improved, and it still does continue to improve treatment adherence and outcomes, because we are offering comprehensive care under one roof for patients. So our system is in such a way that where there are OI services, TB services are also provided by the same nurse under the same roof at the same time, though it's a multidisciplinary management of that patient. And then with community engagement, engaging in incentivizing community healthcare workers enhances TB case finding and treatment adherence, which is crucial to successful interventions. We know that we have to start rethinking about the incentivizations because of the funding ceiling, but we also have community healthcare workers that are supported by government, and also some who are just volunteering, and they've still been instrumental in making sure that we reach our goals. And also the introduction of shorter TPT regimens. We introduced 3HP in 2020 in Zimbabwe, and it was really a game changer because civil society ran with that message, and then it was really acceptable among people living with HIV. Next slide. So this brings me to the last presentation. I think we have, and even the data that we have and what we're seeing on the ground is showing us that we have made great progress in addressing the dual burden of HIV and TB. From our side, it's changes in improvement in our TB indicators, TB HIV indicators. And this is really motivating us to continue, because we know that the current strategies are working. And then contribution from community and recipients of care has been quite significant to the success of TB HIV integration and uptake of TPT. The next slide is acknowledgements. Thank you to all these people who are making this work happen. Thank you very much, and over to you, Bertrand.
Very well done, my colleague and sister. Hey, that was quite fast. I'm sorry. I mean, I wish there's so much to say in such short a period of time. But just one sentence that's coming out of this session is essentially communities can do this. The question though is, as I believe when you do it, if it's not documented, it doesn't exist. And so it's important that we need to do this work and document it and shout through the rooftops for people to listen and change their attitudes, the powers that be. So thank you very much to all the panelists. I appreciate your insights. And unfortunately, we will not be able to do question and answer because we've run out of time. But then again, I know as activists and advocates, we will meet and keep talking about these things. So I will hand over to, not hand over, I will go to the next session to have some reflections of what's gone on in this webinar thus far. And I'll ask our sequent partner and sister and colleague, Rudo, to come in a minute or two, give us your reflections. And then after that, I will hand over to Pragashni on behalf of Dio, who's having technical issues with his network. To also give reflections on behalf of the Khan, and then you, Pragashni, will wrap up and on behalf of ITPZ. But thank you very much. Let's keep the fight. Thank you.
Thank you, Baktrin, for giving me this opportunity. I would just like to reiterate what everyone else has already spoken to, that for us to be able to win the gains that we've been working hard for over the years, both for ending TB and also HIV as public health diseases of interest, we really need to work together. And I like how this webinar has been curated with both having global advocates, country teams, and then the Ministry of Health, just to kind of show that we are one team that's working together. And in the Ministry of Health presentation, we saw how she highlighted the work that they did with the national networks of people living with HIV. To end, I would just like to say, even though in the ICAP sequin scope of work that has been reimagined since February, the TB-HIV community of practice is no longer active, and TB-HIV as a focus area is not really prioritized. That does not mean that TB-HIV should be deprioritized or is not a priority. We are working within limited resources and having to think through how to make better use of resources. However, we still have our TB stream of work that is happening through the advanced HIV disease community of practice. I encourage country teams to continue to work together against these two conditions. Thank you. Over to you, Baktrin.
Pragashni?
Okay, and I've just checked with Dio, but I'm not sure because he had his camera on, but it's fine. I do have, okay. Are you good, Dio? Go ahead. Okay. Dio, unmute. We can't hear you.
Sorry. Thank you very much, colleagues. And it's really a great journey that community and the Ministry of Health that we have worked together, that we need to try ourselves again to see the last mile, how we cannot leave each other behind. As remember, when we are talking about integration, it's something that needs the open collaboration, as we have been trying. But during this resilient time it's the right time that to throw the what I would say, to show that we are working as a team. No one that is, instead of working in a silo as Brace stated. And other things about community needs more of education, at least to hold up accountable for our government. We need to really be ready to respond, of course, but we need to reflect the gaps that need to be filled in as service users. Something this knowledge and expertise that we have already developed through this period we have been in the health setup. It is an opportunity for us at least to advocate for ourselves and really make the better marriage between the community and our government. Other thought of food for thought and reflection, it's about redesigning the roadmap of sustainability, of the better outcomes, because when the community is well set and accountability is well reflected on, there is a high opportunity for success, which means we need to keep this understanding as a community, but as well, we need not to sit back. We should even approach our government to show them that this across collaboration that we have been doing, there is this outcome. But if we are looking about this sustainability, we need to own the best practices and improve where there is a gap. I think I would stop from here and say again, programmatic, we need to work together. Policy-wise, we need to keep ourselves ready to advocate where there is a gap, but mostly we need to at least engage other communities that and address their needs accordingly. Appreciate so much. Thank you. Over.
Thank you very much, Comrade Dio. Pragashni?
Okay, in the last 2 minutes that I have, I would like to take this opportunity on behalf of ITPC Global to thank our special guest, Blessy Kumar, a powerhouse of activism and great feedback, passion, and helps us better understand and unpack the way we think about HIV and TB integration. If ever you want to know more, she is an excellent source of information, more of a library and a hub. So please do make use of her. We really appreciate her attendance today, considering the difficulties everyone's currently facing within their own networks. We do acknowledge the time that everyone has taken today to join this very important webinar. As we lead the way towards HIV-TB integration to sustain our networks as well as our programs, remember we should be focusing on what Blessy, Nadia, and the rest of the community advocacy network, as well as Clorata from the Ministries of Health. We need to focus on how to integrate, why we integrating, and for who are we supporting, understand better some of the barriers to HIV-TB integration, but make sure that our efforts are deliberate as well as intentional. We still have a long road ahead of us in terms of securing sustainability within the current context that we are facing, but nonetheless, we will get there. And with that, I wish everyone a great and a good morning or evening, depending where you're from, and a good night for those that are in the Asian regions. And do do make sure that you keep your eye out for more webinars like these as we stay connected through this information sourcing webinars and capacity building. With that, you take care, and thank you very much, everyone.
Thank you all.
Thank you.